Screen. Okay, so here we go. Okay, so everybody will have a certain amount of knowledge due to their practice in trauma imaging. I hope you're able to hear me very clearly. You can drop your comments on the text box as we go by. As I already mentioned, I will collate all these questions and thoughts, and we will discuss this towards the end of the topics or the presentation. So why have we chosen this topic, polytrauma, which I will explain to you in the next few slides why this is something that is very, 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 very important, and which subset of human beings does this affect. And you will understand the importance of what we as imaging personnel will contribute to this important pathology that the humankind encounters. Trauma is all varied. Obviously, when we mention trauma, we always think about a road traffic accident, but there are a number of other things, you know, falling down from a building, falling down from a bridge, a brawl happening on a Friday or a weekend in a pub, you know, all these things that comes under trauma. If you really look at all those things, the main age factor is these are all young people. These are all everybody just like us who are predominantly affected by this pathology, if I can call it. And this accounts for a significant amount of death in the population. And these are all data that is now available in across the web. It not only causes a significant morbidity to the family involved, but there is also significant financial burden both for the family and the country as well. The World Health Organization, slightly it's a older data, but it says by the next decade we will have nearly 28 to 30% of, you know, all mortality, death secondary to injury. That is, if you just have to put it in simple numbers, out of 10 deaths, 3 are predominantly going to be due to trauma. So that's the significance of the topic that we are talking today. Just to emphasize this point, this is a slightly busy graph with all different colors in it. But what I'd like to make sure is in these two graphs, there's only predominantly 2 points. On the left is to see where road traffic, i.e. trauma, stands for the whole world. It is predominantly in the first 10 pathologies that it really is on the 7th year, and these are all World Health Organization data looking at millions of deaths in the whole world. The one on the right is predominantly of interest to us. This is for our continent, our African continent, and again, road injury, road traffic accidents are among the first 10, and it's a significant number. It's millions here, but here it is 100,000 of population. A significant amount is caused by road traffic injuries. Just a statement to emphasize that road injuries, nearly 1 million of people. In 2016, nearly 3 to 4 years ago, the amount of mortality, death, were men and boys, young people. So with this in mind, we will move along to what happens in our continent. Data is very much limited from our continent. This is a slightly old data from nearly 4 to 5 years ago. This is from a hospital in Nigeria. They looked at around 1,000 plus patients. Everyone had a road traffic injury clinical history. The severity score of the injury ranged from 2 to 15, but on an average it was around 4 to 6. But the important points to take home was the mortality, i.e. the death, is approximately 30% which is 3 patients out of 10 who's had a road traffic incident died. And the point on today's lectures that I want to make and for you to take home is this: injury is not limited to one segment of the body. Multiple injuries. Multiple injuries. If you look at this data and also the data from the world, the mortality is caused by multi-segmental involvement of the body, which we will emphasize as we go along. So what have we been doing so far? I'm sure everybody are involved in plain radiographs, which currently is also being performed quite a lot. And I'm only talking trauma here. Radiograph on the left, pelvic X-ray, impacted fracture, neck of femur, a co-passenger traveling on a car, dashboard injury. The image, the facial bones on the right, fracture of the zygomatic bone. Patient was involved in a brawl in the pub. So we still do a lot of these. Where have we moved along? We have moved along to computerized tomography imaging, but are we doing the right imaging is the question. We actually are 50-50 in this here. What I'm trying to illustrate with these examples are, on the left, we have done a non-contrast imaging of the chest. If you look at the bottommost or the lowermost images, here you have a large liver laceration. So we have to move forward with the post-contrast imaging of not just the chest alone, of the abdomen also in this patient. And by the way, most of the images that are captured on today's presentation are from the African continent, and some of you might even see some familiar images. This is a head injury patient. There's a fracture in the occipital bone at its midline. But actually, as we keep going down to the lowermost slide, what do I see? This is at the C1 level, craniocervical junction. There's a little bit of intraspinal air, and there are a wee bit of air in the paraspinal region. So what do we need to do? We need to image the cervical spine, make sure there's no injury, and there was in this patient. So multi-segmental involvement, the point that I'm trying to make, and appropriate the right sort of imaging. So by doing what we are doing, what are we missing? So what I'm trying to again prove here is multiple injuries in the body. This is again a data back again from 2015. If you really look at the number of body parts involved, equal number, more than one, there are involvement of body parts here. So something that we have to think about when we image these patients. So why do we need to image in trauma? Here are some of the data. Again, published back in 2015 in the American journals. If you look at it, clinical findings were literally misleading in, 1 in 2 patients with regards to trauma. If you just take head injury and loss of consciousness as the primary presenting feature, only around 16% were reliable in detecting other injuries. These are very hard facts. And 20% around who has had a normal clinical examination of the abdomen had an imaging finding which had to change the management of the patient. Very, very important. We are talking life and death here. That's the importance. If I have to dwell this in a little bit detail, again, published from the same journal in 2015, if you look at it, a diagnosis changed in every other patient who presented with a pain in the abdomen after trauma, a similar presentation who presented with chest pains and breathlessness, and 1 in 4 patients with headache had a management, had a diagnosis changed. It's a very, very important reason why imaging is here to stay, and right imaging is the key to the diagnosis. So that is the point that I'm trying to make on top of multiple injuries that present in a trauma patient. Okay, so what kind of imaging should we do? This is the topic today, pan CT or whole body CT. It is a very, very straightforward CT. We are all involved in this. Obviously, we do segmental imaging, but if we put it all together, we get a pan CT. This is of the head, C-spine, chest, abdomen, and pelvis. We have enough data out in the literature to prove that pan CT significantly, not smaller percentage, significantly reduces the mortality, the death in trauma patients, and their stay in the hospital is also significantly reduced. The next couple of slides are why CT instead of other imaging. CT is very easily available, and the setup of CT is pretty much next to the emergency department. So we can get the patient in and out pretty very quickly. And because of all these reasons, we have had a significant increase in the usage of CT in trauma patients. And again, this is a old data going back to 96, so 20 years before. So now I think it would have doubled actually as such. So nearly 30-35% of trauma patients are having the appropriate CT imaging at the moment. The against features realistically are CTs are expensive to our population if you think about it in Africa. And there is always this point about ionizing radiation causing cancer. So we just have to weigh the risk gradation in these patients. And most of the time, since we are talking death here, CT is a great examination to do, a one-stop examination in all these trauma patients. Okay, how do we do it? Fairly straightforward. You all pretty much would know about it actually. Brain and cervical spine. In my department, we obviously do a 0.625 section thickness, and then we 1.25 and reconstruct it to a 0.625, and a chest, abdo, pelvis, and again a 1.25 reconstituted into 0.625 sections. And then we go ahead with reporting these segments in the body, start with head, spine. And what we do is we try and give, because time is of essential, we try and report it as a primary report, which is a quick report that reaches you in another 5 to 10 minutes. And then we sit down to do a detailed secondary review. And so this is how we report on these patients. So now we come to the main part of this study. The next quite a few slides are here only purely on imaging, images. You hardly will have any data for you to read here actually. So let's start. That's a fun bit starts here. We have different patients. I have correlated nearly 5 patients here. Here we have on the left, we have most of you can spot. I will point out the abnormalities here. Isodense subdural hematoma, similar attenuation to the brain. Difficult to spot around the right frontal lobe. But on the left side, you also have a chronic subdural hemorrhage in this patient as such. Not much mass effect, but this is very, very important. And here, this is a patient, again, had a road traffic accident. Here you have a minimally depressed fracture. And then we have a small extradural hematoma adjacent to the fracture. This is a very interesting trauma patient of ours. The supratentorial brain was predominantly normal, but as we come to the last slice of the CT, look what you have. You have hemorrhage pretty much in the foramen magnum, an extraaxial hemorrhage, subdural. Very important. Every slice is important in a trauma patient. And I requested the department to proceed to do a further imaging of the cervical spine, actually. Image here on the right, very difficult to spot. Isodense subdural hematoma. Look at very big on the right side, pretty small on the left side, actually, as such. Very important. Trauma imaging patients, you can have bleed at multiple sites. This actually, I'd like to show you the whole data set if we have time. This is one patient which I think was very interesting actually. On here we have an hemorrhagic contusion with vasogenic edema in the parietal lobe on the left side. And then I was trying to look for the fracture associated with it. I mean, a significant trauma like this will obviously have a fracture, but it was very difficult on a first review of the patient. But then when you start looking very deeply, here we have the fracture line where my arrow points going across the skull base, involving the petrous temporal bone on either side, going through the clivus here, going through the clivus, a very longitudinal fracture through and through the skull base, which is a very, very important finding here, because on top of this hemorrhage, patient's gonna have auditory complaints because this petrous temporal bone disrupts the ossicles of both the ears. So it is very important to look at actually. So it's a very, very interesting patient that I found, a difficult one for my standards to look at as well, but we managed to get the right diagnosis. In this bottom images here, we go down to the craniocervical junction. If you look at on the left side, we have C1 fractures, very important for us to look at, because the risk is your associated vertebral artery injuries with these fractures. Very important, because if this is not identified, we will eventually have a stroke to this patient because of vertebral involvement, what we call a posterior circulation stroke. So important. Okay. This is again a very straightforward. I've given you two sets of images. A gunshot injury. With a gunshot injury, you have an entry wound and an exit wound. But unfortunately, there's no exit wound here. The bullet has entered across the frontal lobes, pretty much stuck in the presylvian frontal lobe here. That's the bullet, hasn't percuted off actually. So this is the tangential of the bullet. I've just given you a VR image just to show the entry point of the bullet here. So as I said, injuries is just not road traffic accident, all sorts of injuries that comes into. So then you can just imagine the number of injuries that you might be involved in your department. So we move from the head to the next region. As we go down the body, we go down to the neck. I have a lot of interesting images to show, but I've just picked up whatever has been very interesting and sometimes difficult in our imaging file. See, neck injuries are predominantly labeled as zone 1 and 2, 3. I mean, the more higher you go, closer to the head, we generally tend to get more complications. So that's the reason of a zone 1, 2, 3 injury. So if you start looking at the images that I've shown you here we have, this is the sternocleidomastoid muscle. See, these injuries are much more common in the neck. I mean, obviously, more of penetrating injuries are common in the neck, because anything like a non-penetrating blunt injuries are taken more by the head rather than the neck. You know, punch injuries or any blunt injuries are taken more by the head and the face, more than the neck actually. So in the neck predominantly you tend to get penetrating injuries. Here we have a hematoma in the sternocleidomastoid muscles, and there is surgical emphysema along the superior muscles of the neck. You would have to go through and look at all the structures. Is there an airway that is injured, has started to result in surgical emphysema, or is there an entry wound, i.e. from a bullet or etc.? Actually, in this way, the airway was the one that was injured. If you look at the bottom two images, two different sort patients, but fairly similar picture here. The patient on the left, complete hematoma with emphysema on the left mastigator muscles, and a wee bit of surgical emphysema here. But the importance is, look at that. It's the branch of the external carotid artery is being compressed here because of the large hematoma that's happened, and it's also pushing the aeropharyngeal, the airway, towards the contralateral side. So whatever is happening, the hematoma around this is yet to compromise an airway compromise, but there is a risk of bleeding here and also an airway compromise. Very important to alert the treating physician or the surgeon. The next one on the right side, a similar sort of a wound, but here we have much more deeper. What you see, this lighting bulb is and pseudo aneurysm from the vertebral artery. So here we have a vascular injury on top of all the hematoma in the left face. Very critical to identify this, because vertebral artery, as I earlier said, posterior circulation of the brain. So we end up, if not treated immediately, ischemic stroke, which can even turn into an hemorrhagic stroke as well. So important multi-organ. So when you have this kind of picture, it's important to scan the brain. And when you're talking about vascular injury, is also all the way go down to look at the aortic arch and the other branches, i.e. the carotid arteries and stuff. So this is where whole body or pan-CT comes along actually. A neck, again a gunshot injury in the neck. Here we have the patient is intubated. We have the bullet which is not exited out actually. This is the right internal carotid artery. The bullet has traversed it. Here I've given you some MIP images which shows an aneurysmal bulge of the internal carotid artery. Significant injury. Interventional radiologist or the vascular surgeon needs to be involved to stent this before it starts to rupture. So gunshot injuries, embedded gunshots in the neck, one up here posteriorly, one right inside. Okay, so from the neck, we move to the front of the face. Obviously, a lot of trauma, whether it's a road traffic or punch injuries, the front of the face, the nose and the eyes are pretty much involved, and the cheekbones. These are the commonest sites that are involved. I've given you some examples now, predominantly looking at the eye. God has given us two eyes, so it's easy to compare. If you look at the lens, because of the injury and the soft tissue hematoma around the eye, or big punch, the lens is dislocated. The punch has been a little harder. The globe has ruptured here on the right. Similar picture, instead of a globe rupturing, here we have vitreous hemorrhage, bleed into the globe. And the one on the right here, again a bullet injury. The bullet has not exited beyond the globe. It's just stuck in the globe here. So we have different sorts of injury. In fact, I have many more injuries here, but due to time factor, I've just picked up the limited ones. So we're still continuing on the orbits. Here, the injury has injured the ophthalmic artery, and it has resulted in a cavernous fistula. You see all the dilated vessels in the cavernous sinus extending into the orbit. So the injury has been that severe. So a vascular surgeon has to be involved to correct this. From the bony point of view, this is what we call a blowout fracture. Inferior orbital floor, completely fractured. Inferior rectus protrudes or displaces into the fracture. This gets caught within it, and the patient starts to have a diplopia, especially at the superior gaze. So important to correct it actually. So all these findings help the surgeon exactly to see what injury it is and what surgically they need to do. So we move slowly away from the eye into the bones of the face actually. I mean, you can call the cheekbones, zygomatic or maxillary, different fractures here. Maxillary fractures, here we have a zygomatic maxillary fractures. Here we have mandibular fractures involving the condyle with dislocations. A lot of these are common. Even in a road traffic accident, because of the sudden brake, you can go hit the glass panel in the front, the dashboard, etc., and you tend to get a lot of injuries in the face. Okay, so we moved on from the top body right into the chest. Pretty interesting pathologies that are involved in the chest region. I've taken quite a few examples here. Here we have, let's start from the top on the left. Obviously a pneumothorax, easy to spot. But the importance here, on top of the pneumothorax, we have significant pulmonary contusions in the lung. But look at the mediastinum. The mediastinum on this image is right at the center, whereas here it's been pushed towards the left side. So there is a mediastinal shift happening because of the pneumothorax. So this is an emergency. A drain has to be put in. More than a drain, once the emergency doctor knows about it, all we do is we puncture, just put a needle in the second intercostal space to just let the air out. The mediastinum comes back to its normal place. It's very important. A simple pneumothorax causing a significant injury in the body. Here on the middle image here, what I'm trying to show you is this crescentric soft tissue around the aorta, a crescent in the pericardial sac. Again, hyperdensity in the pleural sac. If you measure all these attenuation, these are all blood. So pericardial hematoma, pleural hematoma, and blood around the aorta suggests a vascular injury. Very important to note this, because if this increases, it causes a cardiac tamponade. So as we move down to the next image here, obviously you can see the fracture step here. We have a pleural hematoma, a higher density blood within the pleural region. So fractures, always look at other injuries to the other parts of the body. A gross abnormality here, extensive pulmonary contusions. And if you look at the mediastinum, you have the trachea, the bronchi, but these kinds of air should not be there. So it's a pneumomediastinum. So then you have to think, what is causing the pneumomediastinum? Is it an airway that is ruptured or injured, or is it an esophagus? Esophagus being a softy, mushy structure doesn't really get affected by an accident. So you always think about the airway. And here, just look at the right main bronchus. The puncture is here, the wound is here, resulting in mediastinal emphysema. I've given you a coronal image here. The point to see here is right hemidiaphragm. Where is the left hemidiaphragm? Gone. Diaphragmatic rupture. Stomach herniated all the way into the left hemidiaphragm. Diaphragmatic injuries are very, very common. On this image here, gunshot injury, entry wound, exit wound, traversed all the way through the lung with a bit of surgical emphysema on the right chest. So we tend to see all sorts of injuries here in the thorax. And since it is a segment of the body, kind of contemplating or holding multiple structures from vessels, lung, pleura, bones, diaphragms, it is very important to review each and every structure to make sure that the injury is not limited to one structure. So we move down from the chest to the abdomen and pelvis. Similar to chest, again, multiple organs here. So it's kind of a take a pick, really take time to look at all those things. So I've tried to show you some examples here. Beautiful liver, nice homogeneous enhancing from the slide I've given you, but look at the spleen. Hardly you can see the spleen. Hypodensity, isodensity. It's like a spleen that's put in a mixer, mushy spleen. complete laceration, tear, resulting in active hemorrhage because of injury to the splenic vessels as well. And then we move on to the one below. I will show you here. Spleen, nice and beautiful, homogeneous attenuation. Look at the liver, a large hypodensity with an acute bleed here. That's subcapsular hematoma, active bleed because of vascular injury, and we have hemoperitoneum, blood around the liver. So we go here to the top image in the middle, kidney. We have a laceration with a subcapsular hematoma of the right kidney here. So as we come below to the middle of the image, kidneys, liver, obviously we have moved away from the spleen, but look at the pancreas. Nice isodensity, homogeneously enhancing, but there is a step here. That's a transaction of the pancreas. It's a retroperitoneal structure, so we look at carefully at all the other retroperitoneal structures, but none was injured here. So then we move on to the right top image here. What I'm trying to show here is the mesentery. Mesentery, because of its fat, is like black, like the fat that you get in the ventral abdominal wall. But here, look what it is. Hyperattenuation throughout the mesentery, which means there is injury to the mesenteric vessels, hematoma. Same pattern here. Very careful image to look at. We have small little traces of free air along the jejunal loops. Free air obviously has to be from a hollow viscous perforation. Free air in a trauma setting is injury to the bowel resulting in a perforation. These small traces of air, careful examination is needed to identify where it is, and this is a jejunal tear, and the surgeon needs to be involved to repair it. So I've kept vascular predominantly separately, though it runs through the whole of the body. I've kept it here. And if I have to take vascular, I'm talking here mainly on the bigger vessel, the aorta. And as you all know, aorta is both in the thorax and the abdomen. And between those two things, thoracic injury is much more common in a road traffic. Abdominal one, because it's a retroperitoneal structure, generally the incidence of it is very, very less compared to the thorax. So predominantly what I'm trying to show you here is all thoracic aorta. So here the image on the left. Here we have a dissection running through the descending thoracic aorta. Not just that alone, we have hematoma in the mediastinum. There's a calcific density here. That is nothing but the nasogastric tube that's going through. You can look at it, the esophagus is pushed to the right side. So you can imagine the severity of the injury and the blood within the mediastinum. The middle one here is non-contrast CT, which predominantly we don't do in a whole body or a pan CT imaging, but in this case there was a reason that they had to carry on with the non-contrast because of time factors. Here you have a crescentric shape of hyperdensity. This is the precursor for aortic dissection, acute aortic syndrome. Very important, because every little images that we get through are able to give us the diagnosis. In addition to that, we have pleural fluid here. When you measure this attenuation is very high. It's a pleural hematoma arising from a vascular injury. So you can get as much as information even from whatever study that has been provided to us. Image on the right side, another dissection flap with a lot of hematoma going around and extending into the pleura as well. Here I'm trying to show you the same image here, one on a VR and another on a coronal oblique reconstruction, ascending aorta, where you have a focal sacral aneurysm because of the injury, which is not yet ruptured. It's a very significant injury. Vascular surgeon has to get involved here to make sure that this doesn't progress all the way down to the cardiac orifice. So we move on to the bones. In the bones, predominantly, I want to concentrate here on the spine, and the next would be the pelvis one. The spine, because of the fixed 32 vertebrae in the spine, more commonly these tends to get involved in all sorts of accidents and road traffic accidents. It's a very common. I've given you some examples here. C6, C7, facet joint dislocation with a fracture, anterior spondylolisthesis of C6. Type 2 odontoid process, fracture here on the next image. When you have a fracture in one segment of any vertebra, it is very crucial to image the whole vertebra, you know, the cervical, thoracic, and lumbar. That is the standard. Here, it's an obvious unstable fracture involving the posterior elements of the vertebrae with complete dislocation. Cord is at injury or it's already injured here. Here, lower thoracic vertebrae crush fracture, retropulse fragment into the spinal cord, compressing the cord. Patient presents with paraplegia. Very important to get the spinal surgeon involved here, get this operated immediately if we are going to save the lower limbs of this patient. And do not forget, most of these people are young people, less than 40, 45. It is very, very important here where they all have a life to look forward. Next, we moved on to from the spine to the pelvis. Pelvic injuries are very, very common because of its fixed structure. And when we talk about pelvic injuries, it's just not about the bones, because of the structures inside are also very commonly involved. So with any bony fracture, we have to carefully review the structures inside the pelvis as well. I'll show you some here. This is the top left is a fracture, dislocation of the left SI joint, fracture fragment, dislocation of the SI joint compared to the right side. The next image here is both of the ilium and the ischium involving the superior articular acetabular surface on the right side. And as we go lower down, we have fractures on the ischium and the pubis here. But what is important is the bladder is here. Contrast has been given cystogram to see if there is a bladder injury, and you see extravasation of contrast in the pelvic cavity. So there is a bladder injury as well. On the image on the right, here we have a fracture of the right acetabulum. It's the superior margin, but I've not shown you a bone section here. I've shown you a soft tissue for an obvious reason. Look at the left operator internus here, nice thin structure here. Look at it here, a lot of soft tissue with hyperdensity. This is bleeding from the branch of the internal iliac artery. In this case was an operator artery. So what did we do? We went in, vascular radiologist went in and embolized these vessels to stop the bleeding. So very important with bony injuries to also to look at the structures. So I think I've just covered as much as possible in this short interval or the short period, but I want you to take home a few messages. Think about